One of the big issues in any discussion of what goes on within treatment and how it is effective is how you formulate some sort of a causal chain that goes from exposure to a particular treatment or treatment setting or dose of treatment to the outcomes that we're all anticipating that result from treatment. Usually it's abstinence as well as recovery from all kinds of other negative effects of chronic substance use. In this lecture, we're going to talk about the technology model, which is a way of formulating what goes on during treatment. The technology model was adopted from the growth of drug treatments called psychopharmacology, which assumed that the type of drug, the dose of the drug, and the duration of drug treatment accounted for the way that patients receiving those medications change with respect to an infection, with respect to a particular psychological problem like depression. So the model postulated that, for example, within psychopathology, a drug that went to specific brain areas that operated on specific neurotransmitters could alter the way people feel, and by taking that drug at a proper dose over a proper period of time, their brain activity would be corrected from what it was when they were depressed to what it was to before they were depressed. And the mechanism would be the dose and the type of drug they received. When it comes to psychotherapy, that model was adopted, and it was tried in different types of treatment for anxiety and depression and substance abuse. The idea being that a particular type of psychotherapy could change the way people think, the way they feel, the way they act, and when those changes occurred, that would result in the reduction of their substance use, reduction in their symptoms, behavioral symptoms in particular, of drinking or using drugs to intoxication, and that would lead to long-term recovery. So the technology model, when it was applied to substance use disorders and using psychotherapy as specific as possible interventions as could be permitted within the context of a research setting and ultimately a clinical setting. And one way to do that was to specify the treatment. And specifying treatment can be done now with the use of treatment or therapy manuals, which are used by therapists to specify within each session with a patient what they do and what they try to change with that patient. In addition, the technology model paid a lot of attention to the selection of therapists, the training of therapists, and their supervision to make sure that they were following the manual, they were delivering the proper dose of treatment in the prescribed way. And finally, the technology model tried to specify treatment further by monitoring treatment delivery to assess the adherence and competence of the therapist. So by videotaping therapy sessions, by viewing the videotapes, by having a supervisor provide feedback, one could guarantee that the proper dose of treatment was being delivered. So the technology model assumes that the type of psychotherapy that's used, whether it's behavioral therapy or motivational therapy or mindfulness or a way of introducing people to the 12 steps of Alcoholics Anonymous, each one of these things had to be delivered in terms of a prescribed dose. And it was assumed that that type of treatment and the dose would mediate the effect of treatment by changing cognitions, motivations, behavioral skills, or even if it was something that was designed to reduce psychiatric symptoms like depression, to change the level of symptomatology so that it wouldn't interfere with somebody's recovery. One way of characterizing the variables within this model is to look at what is called mediators. A mediator is an intervening variable. It comes between the delivery of a particular type of treatment and the outcome that you're looking for. And intervening variables, according to theory, transmit the effects of a prior variable to a subsequent variable. In this case, it's the provision of treatment or patient's involvement of treatment. We talked about adherence. Patients really need to come to the therapy and pay attention, or even the therapist characteristics. These can all serve as intervening variables. And if the therapists are not compatible with the patients, if the patient is not involved or motivated in treatment, or if the treatment itself is not very good, then the mediators are not working and are not having their desirable effect on changing cognitions, behavior, or feeling states. Here's a model of the black box that was used before mediational models and the technology model was applied to studying psychotherapy. Treatment was assumed to have a direct effect on ultimate outcomes. In our case, we're talking about recovery, but we didn't know what went on in that black box. The technology model postulated mediators that go on between the ultimate outcomes and the delivery of treatment. So those mediators include treatment implementation variables, like whether the therapist is following the manual, and post-treatment proximal outcomes. A post-treatment proximal outcome, for example, in behavior therapy, is the change in the behavior that comes from the implementation of the therapy manual that teaches patients skills to reduce or to stop or to refuse drinking. So if you can demonstrate at the end of a treatment session that the patient has learned drink resistance skills, then you have taken care of that mediator. And what you would expect is that a couple of weeks later, a couple of months later, patients would be practicing those skills. They'd be using those skills that they learned in that therapy session, and that they would be drinking less or refusing drinks and remaining abstinent. There's another model which might also be applied here, which is treatment may have a direct effect on ultimate outcomes, and that is the lower part of this rectangle. But also treatment may operate through these mediators. So there could be changes in the patient's behavior as a result of therapy, but somehow getting into treatment may have an impact on ultimate outcomes independent of what goes on within the black box of treatment. And we'll be considering these different paths to recovery when we talk about mediational models within the technology model. Two more concepts to introduce here: moderators and matching. A moderator is a variable that affects the strength of the relationship, and it can be things like pre-treatment attributes that influence both treatment compliance and treatment outcome. For example, men and women may differ in the way they relate to a therapist who is perhaps practicing a type of therapy that is based on empathy or mindfulness or drink refusal skills. And if gender roles are important, then those characteristics would affect the strength of the effect of that treatment. And men or women might do better in different types of treatment. Matching effects refers exactly to that idea that you can take a particular treatment and match it to the characteristics of the patient and thereby increase the effectiveness of a particular intervention. So keep these concepts in mind as we now proceed to some examples from actual research.